Hello, everyone. This is Adam Stewart from stewartmedicine.com. I'm just going to give you a video narrative of the Ocean Project algorithm for the mental health PSP. So it's a pretty daunting looking flow sheet when you first look at it, so the narrative over top of it helps. So I'll first start by kind of explaining some of the legend over here. So we've got some color-coded legend, and basically what an E-form is an E-form refers to the actual template form, the actual questionnaire that the patient completes on the Ocean tablet. So if there's a sore throat E-form, the patient will be prompted to answer touchscreen answers for yes or no and the duration and drop-down menus. And when they click finish, the chart note is automatically charted into the chart for those of you who have EMRs such as PS Suite or Oscar that are fully integrated with Ocean. For the other EMRs, it's the note that goes into the portal and that you'll copy and paste into your EMR. But basically the E-forms are the actual templates for the questionnaires. E-form actions refer to some kind of bit of programming that goes into the actual templates or the E-forms. So they will automatically load different forms after the initial questionnaire depending on a patient's answers or not. For example, in the PHQ-9, if a patient answers yes to having thoughts of self-harm or suicidal ideations, it will automatically add a follow-up form right after for the patient to complete that will explore the suicidal ideation a little more in depth. Or if not, if the question was no to that, then it doesn't load that. A tablet rule refers to some programming that's done in the background on the actual Ocean portal site, and with that you can have different rules that will automatically bring up forms or E-forms or questionnaires for patients to complete based on certain rules or criteria. For example, in this algorithm, we're saying that if a patient is between ages 18 and 65 and hasn't been screened in the last year, that they will automatically be screened when they're next in and given the tablet. So to take this from the top, patient checks in, they're given the tablet, and they register and they're set up. If the patient fits the criteria in this rule, 18 to 65, and not screened with this algorithm in the last 365 days, then they will be prompted to do a pre-PHQ-2 screen. I'll explain that in a second. But if they don't meet the criteria, they're under 18 or over 65, the rule does not apply to them, so it will just say thank you, have a nice day. Or let's say the patient has come in for a sore throat and you've loaded the sore throat form, and depending on the rule, you manually added the sore throat form, but the rule will automatically screen or not screen the patients for the whole depression algorithm automatically in the background. So if they screen positive if the rule applies to them, and they'll do the pre-PHQ-2. Now the pre-PHQ-2 screen actually seems like a bit of a added work step, but it's more appropriate clinically. Evidence shows we shouldn't be just applying the PHQ-2 screen to the entire population of patients. For one, it will generate a workload that you might not be able to handle or have the resources to handle. So it's useful to maybe target the PHQ-2 to apply to certain risk factors like chronic pain, maybe if the patient has chronic pain, or they drink more than 14 alcoholic beverages per week, or if they have chronic diseases such as COPD, or family history of depression. Those risk factors, this pre-HQ2 screen asks them those questions. If they answer yes to any of them, that's a positive screen, and they progress down to the PHQ2 screen, which is automatically loaded. But if not, if they don't have any of the risk factors, the algorithm stops and the tablet is returned. So if the patient does the PHQ-2 screen and they answer yes to one of the two questions, that's a positive screen, so it'll automatically progress down to the PHQ-9. And again, this is all happening automatically without any manual kind of intervention, so it's really great way to kind of drills down automatically. But if they're negative on the PHQ-2, the algorithm stops. Now, sometimes clinical suspicion, or often clinical suspicion, does override the general screening. So this is all the general screening, but let's say a patient's coming in and for insomnia or something that the clinician or the staff suspect they should be screened for depression. They can manually add one of the e-forms that overrides all the rules and just in either PHQ2 or PHQ9 depending on the desire there. So if the patient does the PHQ2 screening and they're found to be negative, again the algorithm stops. If they're screened positive that yes, the diagnosis of depression applies, a few things happen. One is that automatically the patient is prompted to do a G87 for anxiety, as well as a general depression kind of questionnaire that gets to the basics of the stressors and what the patient's interested in for that visit. Basic depression history. Those will be automatic for all patients screening positive here. Now, depending on the answers, if the patient is answering yes to questions of it's affecting concentration, the PHQ-9, BCCCI, which is a scale that applies to the severity of memory impairment or concentration impairment in depression, will be automatically be loaded afterwards as well to dive deeper into that. Or if they answer yes to it's affecting my function, the Sheehan disability scale will automatically be loaded. Similarly, if they answer, as we talked about, yes to self-harm, the suicidal ideation template is loaded. Now, this is where the purple box, the clinical action, is required as well, because if we're hitting these answers, then it obviously requires clinical assessment to look into if the patient's safe to go or needs a Form 1. I kind of skipped over this part, but what happens here, this is the control, what's called a controller e-form. Now, on the surface, the patient sees is basically a one page that says, thank you for completing this tablet today, and it says, click next. But what's happening in the background is there's actually some computer programming going on that this controller e-form remembers what the PHQ-9 score is from visit to visit. And that will become important down in the follow-up visits because it will automatically rescreen patients at different frequencies depending upon the severity of their last PHQ-9 score. For example, if a PHQ-9 score is really high in severe depression, they are screened more frequently, whereas if it's mild or in remission, the tablet won't come up and bother them. The screening algorithm won't come up and bother the patient again for 6 months to a year. I'll come back to that in a second. So at the end of all this, the patient has done whatever forms have been applicable to them. They click finish, and all of the appropriate notes are stamped into the chart or into the Euroocean portal. And it's a great way to get a lot of clinical history and deep, thorough history and metrics right at your fingertips before the visit even starts. So let's say patients are coming back and they've already gone through this algorithm and they've been diagnosed with depression. So what will happen is that the controller, again, will rescreen patients on different severities. So if the last PHQ-9 score was less than 5, meaning in remission, it won't rescreen them for another year. If it was minimal, like 5 to 9 range, it will pop up. It'll take at least 6 months to pop up again. If the PHQ-9 was 10 to 14, it will take at least a month before it pops up. But if they were over 15 on their last PHQ-9, it will screen them in as little as 2 weeks. And that's all happening automatically in the background. So the PHQ-9 is being rescreened. And again, similar process as above, we have the automated actions that are loading the different scales depending on the answers and as well as the depression history. One added thing here is the FIBSR scale on follow-up, and that's a scale that asks patients about the severity or scores the severity of side effects from depression medications. So if they answer yes, they're on medications and yes, having side effects, it's the e-form action prompts them to do this FIBSR scale as well. If not, it's not loaded. So, and then this whole cycle kind of continues, again, based on the severity of the last visits. The frequency depends on the severity of the last PHQ-9 score. One final item here is that sometimes our days are very busy and you might be having a very complex visit with a patient with, say, diabetes and congestive heart failure, and you just don't have time. You don't have time and the patient might not have time to do a ton of different forms templates. So what we've done is we've made a skip mental health screen e-form that can be manually loaded, that just simply turns off the algorithm for that visit. Not forever, not for months, but just for that visit. If you're having a busy day, or that patient is having a busy visit and you don't have time to really go into the depth that this goes into, then it can be manually overridden, and that's useful on a clinical case by case basis. So that is it.